So, welcome everybody. I'm so glad that you could all join us today here with Garfunkel Wild. We're back here in our compliance department, bringing yet another webinar to those in the industry and the healthcare industry related to compliance issues. We do it throughout the year. If you ever have a topic you want us to speak on, please don't hesitate to reach out to me or one of my partners, and we'd be happy to add it to our presentation list for next year. Today, we're here to talk about the HHS-OIG's Nursing Facility Compliance Program Guidance. And why is that important? Well, it's been, I think it was 2008 was the last time the OIG published guidance to nursing home facilities, specifically on compliance programs. And when the OIG speaks, it's time for industry participants to listen. And who better to help me present to you today about what the OIG has to say than my partner, David Traskey, who spent the better part of a decade as counsel for the OIG. David brings years of experience from the OIG, and he's able to share critical information about the government's perspective and their expectations about providers' compliance with compliance program requirements. And when we're talking nursing homes, my colleague Colleen Pierson has to be included. She is a leader in New York on nursing home regulations. She assists all types of long-term care facilities. She spent over a decade in state government in various roles and brings, a unique perspective to nursing homes. And certainly if you're in the nursing home business, you already know Colleen. And so with that said, we just had a issue with our slideshow, but that'll come back up in 1 second. And we'll get this underway. 1 second. Okay. Okay, we're back at it. Thank you. All right, so why is this important? We really need to cover the risk areas identified by the OIG and its guidance. And they really hit on 4 risk areas, with the last one kind of being the kitchen sink. The first area that we're going to address is their tie of quality of care and quality of life, kind of your requirements of participation in Medicare into your compliance program. They're leading with this for a reason, because to them, this seems like one of the most important things for compliance program requirements that has been lacking. And it's one of the first times I can think of, David and Colleen, where we've seen the OIG and a government agency actually try to make that connection in some real substantive way between quality of care and compliance. It's the first time I can remember it. I don't know, David, if you remember it as well, or Colleen. But to me, this leapt off the page as something that you really need as providers to be aware of. The next thing is what we would expect, but falling into, risk area number 2, your Medicare and your Medicaid billing requirements, and we'll cover what the OIG had to set on that. Risk area number 3, also more traditional, the kickbacks, talking about those relationships and those referral relationships that concern them and that have areas for that are susceptible for abuse. And then, like I said, there are other notable risks, kind of the kitchen sink, where they dump everything in there that you should really be covering and doing your risk assessments to cover. And they also have some evaluation considerations and some key takeaways that we think are important for you as you leave here. So we really appreciate you joining us. I think we're ready to get into it here. So David, why don't you take us away here?
Yeah, sure. Thanks, Rob. I appreciate it, and happy to be here with you today to share some insights on OIG's latest guidance document. So, since 1998, OIG has issued in some form or fashion voluntary compliance program guidance to different segments within the healthcare industry. I think it was probably end of 2022, beginning of 2023, OIG put some materials out there where they talked about, kind of wanting to modernize their operations and sort of get involved in a more concrete way with guidance that was both timely and useful to the provider community. And so what you see is back in 2023, OIG issued the first general program guidance about a year ago, actually. Um, and now this most recent one that is industry specific to skilled and other nursing facilities is kind of the next chapter in OIG's kind of modernization efforts to provide more dynamic and useful information to the provider community. And I think, what's important here is it's highlighted in red. It's voluntary, it's non-binding compliance program guidance. I would say that it sort of falls into the, best practices bucket. But as we get into it a little bit further, you'll see that one of the other points that OIG makes is that, this is not exhaustive, and that there are, providers should be would be well reminded to consider sort of their own particular risk areas also.
Yeah, I agree. Like you still have to be doing your risk assessments by your building is at the end of the day.
Right.
We can go through this. You better be covering it when you're doing your own, but you can't limit it to this.
Right, and and to Rob's point at the top of the webinar, why now, right? Well, we have a little bit of the backstory from OIG that I just mentioned, but also I think what you're seeing now is for the first time in any kind of meaningful way, OIG is linking quality of care issues to the overall or overarching umbrella of compliance. And one of the reasons that we're seeing this now is that the current Inspector General for HHS, Christy Grimm, she's been in the seat now for a little bit, but she has been very vocal in her public statements and also privately internally within the organization that quality of care and quality of life are, particularly in the nursing home space, are key priorities for her.
Hey, David, if you could get closer to your mic, we just had a comment and thank you. They're saying they're having trouble hearing you.
Yep. Hopefully, is that a little bit better?
I'll let
Let the audience let me know.
yeah,
All right.
they like you so far though.
All right. Whew, all right. That's good. So as I was saying, the focus now on quality of care and quality of life shouldn't necessarily be surprising based on the current IG's stated goals and preferences, upon taking the helm at the OIG. Okay, great. Thank you, Susan. I appreciate it. Very good. Everybody can hear well. And I think the other thing that you'll see in this document as you review it is that there's a real focus on this idea of compliance being a proactive team sport, right? So it's no longer enough to just sort of set it and forget it with your compliance policies and programs. And it's also no longer the case that, sort of the compliance group can be siloed, by itself or sequestered. It really needs to be kind of a team effort.
Yeah. Okay, so let's get right to risk area number one. So by your agreement or your entrance into the Medicare program as a provider, you're expressly agreeing to comply with the CMS requirements of participation related to standards of care. Your failure to provide quality of care, the OIG's warning, poses a risk of fraud and abuse, including liability under the False Claims Act and the civil monetary penalties. Like you'll see CMP or in there for a civil monetary penalty. We might have FCA for False Claims Act. They've lined up very specific concerns, and no surprise here, we kick it off with minimum staffing. They then turn to appropriate resident care plans and activities. They are talking about the change in resident profiles with the baby boomers coming through. There's a focus on medication management and proper MDS reporting, as well as resident safety. The, the thing that is important about these conditions of participation, and for me, I'm very much involved in False Claims Act investigations, investigations of nursing homes and other providers. This is something the government has been doing for years. They've been doing it since I started litigating these types of cases. And there's a big battle now over these kind of, is this, well, I'm just required to do this to participate, but not tying it to money. Well, now they really want to go a step further, and you'll see in these slides saying, well, if you're not doing these things, you're not meeting up to the standards and the certifications that you give when you submit your claims, and it's a problem. It's becoming a false claims, and they're really mentioning this throughout the guidance to the point that you really need to be cognizant of it, because it's really, you should treat it as a signal of how enforcement actions are going to continue to be looked at in this light. So let's get into it a little bit more with staffing levels. Colleen.
Yes, minimum staffing, everybody's favorite topic right now. As I'm sure you are all aware, CMS recently implemented a minimum staffing rule aimed at reducing the likelihood of residents receiving unsafe or low quality care. While there is a minimum requirement, OIG is stressing that your higher acuity patients will likely require higher total RN and CNA staffing levels. So merely meeting the minimum requirements will not necessarily keep you out of the woods if your quality of care is low. OIG notes that if staffing is so low that it leads to grossly substandard care and poor clinical outcomes, the government may prioritize bringing an enforcement action. This ties into the new emphasis you're seeing on quality of care in this guidance document.
Yeah.
Includes a new requirement that SNFs or nursing facilities have a registered nurse on site 24 hours a day, 7 days a week to provide direct resident care. That's a big one for facilities. And, you know, this rule has received a lot of scrutiny and is currently being challenged in federal court. So the future of the rule is unknown. And while CMS implemented this rule, Congress historically enacted very specific statutes on minimum staffing requirements, which do not, as an example, obligate an RN to engage in direct patient care and offers more flexibility in the staffing required. So in the past, there were several instances where Congress actually voted down proposals to change these requirements. And so the argument that a lot of people have, and the argument being made in federal court, is that CMS has exceeded their authority in issuing this minimum staffing rule. And so even if this rule were rescinded, which is a possibility, you still have to keep in mind that many states, including New York, have implemented minimum staffing mandates that are stricter than this rule, and you will still have to comply with those.
And you still have to do your assessments, right? You have to do your assessments of your building each year. And getting, this important that you noted about this substandard care and poor clinical outcomes that they referenced, because that was kind of what I was alluding to about the False Claims Act, where the government asserts that it's worthless services, that these services have zero value because your compliance is so below level that they shouldn't be paying for it, making it a false claims. And now you find yourself in an arena where you're not talking about surveys, deficiencies, and maybe a penalty. You're talking about bigger investigations where the stakes are higher, potentially having triple your damages per claim penalties. So we've seen these arguments many times before, but now we're seeing this buried, right into the OIG guidance.
Yeah, Rob, and I would just add one other thing to that, which is that, if you're in this, posture with the government where they're alleging substandard care or essentially worthless services, in addition to all the pitfalls that Rob mentioned, one of the other things that you're going to end up having to do is to retain an expert, most likely, to speak to the issue of, quality of care, standard of care, and whether or not those services are in fact substandard or below the expectation. And so that's just sort of another, another thing to think about as you can kind of hear the cash register moving, if you're stuck in a government investigation with this particular topic.
Right. And so why are we here though, right? And why are they printing this? So we can learn to, kind of get away from it and protect against it and have, why don't you talk about the mitigation strategies? Because, embedded throughout this document is trying to give guidance to the industry. So why don't you talk about that a little bit for our audience, Colleen?
Yeah, so the mitigation strategies that are suggested in the guidance document include hiring a director of nursing to set the tone for achieving high quality standards, offering competitive compensation packages, investing in ongoing education and training for existing staff, and focusing on relationship-based care, both to increase the quality of life for residents and also the quality of work life for staff. I made mention here of the PBJ data accuracy issue because while this wasn't specifically outlined in the guidance, it's very important for providers to make sure that they are accurately completing and submitting their direct care staffing information to CMS's payroll-based journal system on a quarterly basis, because this data, among other things, is used to identify your compliance with the minimum staffing mandate and to also analyze the relationship between the staffing levels and quality of care being provided. So you want to make sure that you're accurately reporting this data to CMS, because audits of this data are being conducted at the federal and state level to verify the data you're submitting. So audits will look at things like whether you've removed mealtime hours from the data for exempt staff, whether all of the staffing hours submitted include hours not worked in a SNF unit. If audited and errors are found, your staffing levels will then be adjusted according to what the audit has verified, and that could impact your staffing calculations and then your compliance with these mandates. So they are looking at these things. It is out there, so make sure you're reporting accurately.
Yeah, we have them in-house. Like if you're not getting them, maybe they just didn't get to you yet, but we are certainly dealing with that. And later we have to talk about how that ties into some of this PDPM stuff and your staffing, right? Because this
Yes.
starts to be a theme that is woven through different areas here, you know, about your, acuity levels and your staffing and your PBJ, and you need to match them. So we'll cover that, but you kind of there's concepts here and themes here that are interconnected, and really be mindful of building this into your compliance program, right? Because all of these things they're talking about are, okay, what do you need to take away from the staffing section as we move into the resident care discussion? Well, I need to have staffing levels built into my compliance program. My committee needs to be looking at this. This needs to be on my work plan. My risk assessments need to be including, looking at staffing. I'm looking at my data accuracy. So these are things that you're going to be expected to monitor, um, to be, to follow what their guidance is and really to protect you and to prevent fraud, waste, and abuse. So that's kind of like how you keep tying this back to your compliance program. Um, but now let's talk a little bit, David, about their focus on care plans and activities.
Yeah, so I think just too as well, Rob, just to piggyback on what you were saying, I think one of the other things that is sometimes unknown in the provider community is just how much data OIG has access to, and how it's using that data to proactively bring cases against providers who may not be complying with the rules in the ways that they should. And one of the things that we're seeing an uptick in is the government looking at the care plans, not only because they're a condition of or requirement of participation, but what we're seeing is in audits and investigations and evaluations, and even frankly in providers who are currently under corporate integrity agreements with the OIG, that their care plans are being scrutinized in ways that probably haven't been done so in the past. And whether it's your initial assessments or your care plans, as many of you know, there are certain elements that have to be included in care plans, like, for example, a list of healthcare services for the patient, who needs them and who will provide them, the frequency of those services, and a list of needed equipment and supplies, special dietary considerations, and the patient's health goals and how they plan to achieve them. right? So those are all things that, we should be paying attention to as we go about putting together the care plan. And I think one of the other things that sort of jumps out to me, and it's mentioned here in the mitigation strategies, is again, this quality of care and compliance are continuing to be intertwined. And that, it really is a team sport, right? You're going to have to work with clinical staff as well as the compliance group to make sure that we're checking all the boxes. And lastly, what I would say is, to the extent that this guidance document indicates that it's voluntary and non-binding, I think that's correct. But what I would say is, in some form or fashion, there's going to be certain elements to this document that are going to apply to everyone. Um, and for better or for worse, there's going to be some benchmarking by OIG as far as some of this guidance goes and how you're applying it. All right. And then I think too as well, right? There's an increasing awareness or recognition that as we live longer as human beings, that there's a greater need for the services that are provided in skilled nursing and nursing facilities. And I think certainly we tend to think about the one end of the spectrum with respect to older patients. But for a variety of reasons, what they're also now seeing is that there's younger patients that have different needs who are sort of in that same boat as well. And in particular, I think as there's a growing acceptance in terms of discussing behavioral or mental health needs, I think that that's one of those items that maybe sometimes gets overlooked in care plans. And it's certainly something that we should be more cognizant of, making sure that we're doing those assessments and providing those services, but also documenting that we're doing those things as well. Because sort of as you may know, the government's perspective is, if it's not documented, it didn't happen. So unfortunately, you don't get credit for thoughts. So it's just a good reminder to make sure your documentation is as strong as it can be.
So,
Yeah.
sorry, Rob, just
Oh,
another priority is medication management for OIG and minimizing conflicts of interest in pharmaceutical decision making. This is to reduce the likelihood of medication related adverse events and to ensure that pharmaceutical decisions are objective, unbiased, and based on the best interests of the residents rather than positively impacting your quality measure. An example of this is the misreporting of schizophrenia on the MDS to impact quality measures related to antipsychotic use, because CMS, as you know, excludes residents with schizophrenia from this measure. So you want to make sure that you have clinical justifications for everything, and that you are reporting based on the best interests of the residents and not another reason. Some mitigation strategies include providing consistent and comprehensive training on medication management and documentation, identifying root causes of errors and how to reduce future recurrences. And as David mentioned a few times, this interdisciplinary team approach to assess the appropriateness of the medications being prescribed. You can limit drug switches to licensed prescribers only, and ensure remuneration to pharmacies consultants is fair market value and does not consider volume or the value of drugs. So again, you're seeing this patient-centric focus in OIG's guidance.
yeah. Yeah. And so let me talk a little bit. They have resident safety in here. And I just want to add two things. I'm a really big proponent of, giving guidance and advice that you can take back to your facility and implement. So what should you be doing at the end of this? The purpose of this is to educate you, to let you know what's in there, and to get your mind going and making sure you're on top of things. And if you hadn't heard it and you hadn't read it, we're at least giving you this overview. But you need to be printing this out, the guidance out. You need to be getting in a room, and you kind of need to be, reading it and then grabbing the right people together, grabbing your compliance officer, grabbing your DON, grabbing your administrator, grabbing, senior members of QAPI or whatever it is, where you have your quality people, making sure folks are looking through this and then figuring out how you're going to build it out and how you're going to kind of have a synergy between your quality and those who really focus day to day on quality care, resident safety, et cetera, and those assisting with the compliance functions as well, and figuring out how to assess it, how to include it, and how to handle it within the compliance kind of group there. So sit down with your team, make sure people have copies, read it, and talk about the strategies you're going to use to include these items into compliance. So like resident safety, okay? It's an essential component of high quality care, and they want proactive monitoring because we want to avoid, what we know the the DOHs are coming in on, that abuse and neglect. Okay. They're on that. They're looking at that. We see it day in, day out. Our phones ring with it all day, unfortunately. Or we have issues with staff, or we find out we didn't screen staff correctly. Then there's things of emergency preparedness, life safety, infection control, which have been really hot the last, I could say COVID with infection control, but like the life safety, these life safety codes have been a beast the last, 18 months to 2 years, especially here in New York. And then the other thing is your facility discharges, the ones you're initiating because you can't handle the patient anymore. There's a real focus on that too. They understand patients can be difficult. They're not looking to overburden facilities, but at the same time, they want real efforts to be made and a culture to be that they're going to try to prioritize being able to handle these things and then doing it correctly. So what do they talk about for you to mitigate this? It's make sure your culture is developed through communication, training and education, and then monitoring and remediation, right? But that training and education is one you'll see if you sit down with this document with your team. Training and education is one that's carried throughout each of their topics. They want to make sure that your folks are on the same page, that your policies are effective, and that you're being trained on them. They want standardized recruitment screening practices to making sure we're not bringing in people we shouldn't. They want plans that address, your physical or mental trauma, residents may experience. They want, again, training that, deals with that infection control and many lapses there are, and evaluates the ability, and availability to obtain necessary supplies. And again, training, it's like, it just doesn't stop, right? It's training on inappropriate discharges and making sure you're documenting permissible reasons so that you're not getting jammed on it. It's okay to do it. You just need to do it correctly.
Hey, Rob, I would also just add one other thing to that. When you're talking about communication and the culture, over my years in government, and even now since I've, joined Garfunkel, what I think the most successful facilities are ones where the compliance team at the facility it is viewed as an ally, right? They're there to help and keep you out of trouble and help sort of navigate the process with outside counsel if you get into trouble. But I think to the extent that the relationship can be fostered such that it's not an adversarial one, I think that goes a long way in terms of sort of developing that culture that's going to lead to some positive results.
Right. Good points. All right. Colleen, you want to talk about billing requirements? I think this is a pretty important one too.
Yeah, I think, David, I know you had things to say on it as well. The common risk areas include, but are not limited to, insufficient documentation and duplicate billing, false or fraudulent cost reports, and compliance with the SNF 3-day rule and consolidated billing requirements. So accuracy matters, and proactive auditing, training, and monitoring are essential. What I will talk about, and David, I know you want to talk about the other items, is the new PDPM system. Everybody is is wondering about how this will affect things. This is certainly an area that warrants heightened importance, and ensuring clinical justification, as I mentioned earlier, is key because you may be told by consultants and others in the industry that in order to maximize your reimbursement under this new methodology, you should be ensuring that you're capturing certain things like depression, for example. Because unlike RUG, where therapy minutes were a major driver, with PDPM, patient medical diagnosis, clinical complexity and patient outcomes are very important. However, it is also important that you have a true clinical justification for this, because if you don't, you risk enforcement by OIG. Again, they're looking at quality of care more than they ever have before. So you want to make sure you have your ducks in a row and are not, putting in things into the MDS solely to drive your reimbursement, because they
Yeah.
will find that.
Yeah, I have to jump in on this one, right? So depression, right? We talk to, people on the other side, our adversaries all the time. We're in touch with them, and I've had conversations about, they're seeing spikes in diagnoses getting added. And, I think one of the reasons too OIG is coming with this now too with the baby boomers is we're gonna be handling a bigger wave, and the more fraud and abuse you can prevent, the better. Um, but you better be able to back up why you have a diagnosis in that medical record. Um, because if it's increasing your acuity scores here and your PDPM, there better be something tied to it other than, well, I saw it on another document. What are you doing with it? Have you ensured that the evaluation is correct? Is it something that you copied off of, the intake from, or from the discharge from a hospital? Did you have the person seen? Are there medications? Is there treatment related to it? They're looking. They have the data. They are mining the data, right, David? Like that better than anyone. They are in there and they are looking, and they're going to find it, and they're going to look at this, and they're going to look at your acuity, and they're going to look at your PDPM, and they're going to say, well, let me see those staffing levels. Give me those PBJ reports, and this is the interconnection we're talking about, and that documentation is, you know, you better be able to substantiate what you're putting down there as it relates to this. But on that data, David, I remember you and I, when I was trying to get you to come here, talking to me about what you were doing at OIG and your knowledge of how they have that perspective and those tools.
Yeah, I mean, and again, it's one of those sort of behind the curtain things that I don't think most providers really know all that much about, or they appreciate to the degree to which OIG is able to scrape and mine data from so many sources. And one of the things that I used to do as an attorney on the affirmative litigation branch was to go through that data to look for outliers, right? Who's a huge outlier for, you know, um, compared to their peers,
Right,
in the
right,
same geographic region. Um, and there's this idea, I think, perhaps it's being dispelled less, is that, you know, OIG is too busy, and they're not going to catch you, or they're not going to catch people who are, engaged in fraud, waste, and abuse. And while certainly the mission of OIG has grown, so has their resources, and so has their technical expertise, as far as using data to proactively bring cases, right?
And
yeah,
David, right, like it's a double-edged sword, because the more people you have in your facility with higher acuity issues, again, the more staffing you're going to need in order to be in compliance. But also, what would you think if you were looking at data and you saw that all of a sudden this facility had, you know, 5 times the amount of patients with depression? It may increase your reimbursement, but do you have a quality of care issue? Is that what it's projecting as well?
Yeah, I think that's right, and I think it also speaks to Rob's point a moment ago, right? Just being an outlier in something in and of itself is not wrong, provided that you're able to substantiate the reasons why you are that outlier. So it goes back to Rob's point about, do we have the documentation, the assessments, the care being rendered for somebody who has depression, or or did we just sort of copy it off of a some other note without any kind of real basis or underlying support? So, if I'm in the OIG and I see that, as an outlier, I may say, huh, like that's kind of interesting. Maybe that's a phone call or an email to the provider to get some additional information. And if that information is provided to my satisfaction, that the depression diagnoses are appropriately documented and all that, then I'm going to close my book on that one and move on to the next one, because I know that there's going to be a certain percentage of folks out there who are outliers who can't support it, and those are the type of people that end up in OIG's radar.
Yeah. Let's turn to kickbacks now. And I think that's a great discussion and just shows, the kind of things that we're dealing with and know behind the curtain there. But let's turn to a little talk on a more traditional compliance topic, which is kickbacks. Other than don't do them, let's talk a little bit about them.
So as you all know, you must comply with the federal anti-kickback statute. And one key to understanding compliance with this statute is the ability to identify arrangements with referral sources and referral recipients that have the potential for fraud and abuse. So in this guidance, OIG actually goes through and they list expressly suspect arrangements to look out for, which include, but are not limited to, free or below fair market value goods and services, discounts in the form of price reductions or swapping.
Yeah, that one, I just want to cut off on that one's always swapping. I just want to make sure people know that's the physician who wants to come in and treat and tells you, well, he's going to charge you kind of a basement, bargain rate for your Part A stays in order to get your Part B stays and bill those at the full Medicare and get his full Medicare dollars on Part B stays, or so that's kind of what the swapping thing is. Go ahead. Sorry.
Yeah, no, you and David are the kickback experts here. So arrangements for services and supplies between the SNF or the nursing facility and physicians, or outside suppliers and providers. So the other thing is long-term care pharmacy and consultant pharmacist arrangements, hospital payments to nursing homes to accept discharged patients or reserve or hold beds, hospice payments that exceed Medicaid service or room and board rates, and then joint ventures with other healthcare entities. So those are some of the ones that were expressly pointed out by the OIG.
Yeah, the joint venture one is one that comes up all the time. And it reminds me to remind you, providers out there, that if you need to get the attention of your your ownership, when you dig into this guidance, you'll see that this isn't just designed for your administrator or your director of nursing. It's for your owners. It is for your operators. It is for your chains. It is for the ownership up in their control companies. It is for your management services organizations. They know these structures. They know them well, and they want this compliance to be coming from the top. And so when I was thinking joint ventures, it really reminded me that to share that with you, because the joint venture requests are usually coming from the top, right? It has to do with, we want to structure some deals, and there's plenty of guidance on that. And when we say that we know what their, things are coming from the top and the way things are running, we get right to this concept. But they created the new tunneling. We know what it is, but I feel like I'm stealing from you, Colleen, but this is when you're
No, it's
hiding the
okay.
profitability by overstating payments for operational expenses in order to funnel them to related parties. So you can do this in real estate transactions. You do this when you're outsourcing your admin or management services with commonly owned facilities where you pay in excess of FMV. So they're looking at everybody involved, all the players involved, not just what's going on in the building. This document is talking to owners, it's talking to the operators, it's talking to the investors, and they want that commitment and understanding that this has to come from the top. I'll turn the self-referral law to you, Colleen.
Okay, yeah, and just another note on that. This is one of my favorite topics, but that, doing business with related parties is not illegal. And oftentimes it does make financial
Good point.
sense. But there are new federal disclosure requirements that you must comply with for the sake of transparency. And it's important to ensure that you are paying that fair market value for whatever goods or services are at issue with these related party transactions, but that you're also making these necessary disclosures as they are a requirement of participation. And so they're not illegal. Don't be afraid to disclose them. Make sure you're getting them in. Just make sure you're paying that fair market value. And then with the physician self-referral Stark law issue, skilled nursing facility services covered by Medicare Part A payment are not designated health services under Stark, but SNFs may be considered an entity providing these services if it provides certain Part B services to enrollees who, one, are in a non-covered Part A stay, or two, reside in a facility that is not certified as a SNF by Medicare.
Yeah, and Colleen, I would just add to that. I mean, this is a good example or a good reminder, I guess, to know what type of stay it is that your patients are in. Um, for a lot of different areas, there are different rules for whether you can bill directly or whether you're getting payment from someone else, depending on whether or not you're in a Part A stay or not. And what I have found in my experience is that oftentimes providers are unsure what the status or the type of stay it is that a particular patient is in. So this is just a reminder to make sure that you know whether they're in a Part A stay or not, and whether or not you have to pay closer attention to Stark.
All right, good point. Let me answer a question here. We have two questions that I'm going to try to get to the first one last because this one is directly on okay, we were asked, can you elaborate on kickback implications of arrangements with hospitals? Okay, and so what the OIG has said, they know that hospitals and hospital discharge planners are frequently making referrals of Medicare, Medicaid patients to nursing facilities and vice versa, right? We are sending patients out to hospitals. And so what they said, be aware of your suspect relationships, any kind of remuneration, things of value being given back in between. So they talk of, if you're sending to a hospital to induce the hospital to refer to you, or if you have some kind of an agreement, say, I'll refer to you if you refer to me. Anybody providing, free items for hospital discharge planners or charity care to some patients is another thing they list as a favor to the hospital. Or if you go and solicit and receive from a hospital, goods or services that are less than fair market value, nursing or other staff to provide for services at your facility for free, or money to facilitate your admissions process. Those are the ones that they've kind of stuck to in their guidance. So I hope that answers your question. So all right, let's turn to 15. I think that's me. So the other notable risks, we have the anti-supplementation rules about, you need to accept payment and can't charge an enrollee or someone else, an amount in excess of what must be paid under the plan. You have HIPAA, data, breach issues and notification rules. You want to make sure that, you're covered entities and you want to make sure that you're following your obligations, that you have appropriate business associate agreements in place. And then, of course, civil rights. You don't want to be discriminating against program federal healthcare program beneficiaries or anyone else. And so that brings us to slide 16. That is,
Yep.
I believe, David,
Yeah,
right?
that's me. So, as many of you know, for many, many years, OIG has put out documentation or guidance on the 7 elements of effective compliance programs. There's plenty of material out there on it. But again, it speaks to the point that Rob was making earlier about the expectation that there is this tone at the top. And that's how sort of the other elements of the compliance, an effective compliance program fall into place, is if you've got the tone at the top, saying compliance is important, we're going to make it a priority, and this is how we're going to do that. Then other employees, other folks in the C-suite tend to fall in line in that way. And I think one of the things that jumped out at me in reading this most recent guidance is that they include investors now as a group of responsible individuals. And so it's not enough necessarily to just sort of be the man or the woman behind the scenes bankrolling, the deal. There's an expectation now on OIG's part that investors, along with other people that we would normally expect, to take a more proactive role in making sure that the facilities are complying with, rules, regulations, and requirements. And then kind of, as we mentioned earlier, I think in that last bullet point, you have situations now where you're going to see this interconnectedness between compliance functions and quality of care and safety functions. And again, this is a common recurring theme in OIG's guidance is that they want to ensure that folks, in particular compliance officers, when they are doing their work, that they are not being unduly influenced by anyone, and that they've got a direct line of communication to the folks at the top.
Right. And that's why I just flipped the slide on you to kind of close that, close this piece out is, and what are you supposed to be doing, right? Regular risk assessments, internal reviews, and monitoring. You got to be proactive. And these things that you're doing, identifying those weaknesses and errors to prevent future recurrence, and coordinating all of these things together should be leading, right, to reports up the chain. Compliance officers should be preparing reports and speaking regularly to ownership, presidents, CEOs, whoever it is, however you're structured, on these compliance activities and how these things are, being monitored, and what are the outcomes and what are the results of your reviews and audits. David, can you take them through kind of like these key takeaways, and then I really want to answer the last question and leave this with kind of the practical advice, because the last question is the first question we got was really a good one, and I saved it for the end. So if you could just hit this, and then I'll
Yeah,
close
of
out
course.
that, or Colleen, if you have more to add, of course, jump in at any point.
Yeah. So just to wrap up, I mean, for those of you who are familiar with the 7 elements of an effective compliance program, these 4 takeaways here should not be surprising to you. If you're not familiar with those 7 elements, I would encourage you to take a look and learn a little bit more about those elements and how OIG views them. But essentially, this guidance document, it's not a one size fits all or all inclusive, right? And so ultimately, these are recommendations that OIG is making. However, that doesn't give you a pass on things that may be unique to your organization or your facility. You're still responsible for those. We talked a minute ago about the tone at the top, and having that sort of, and the culture, right? And having those commitment to compliance, which now includes quality of care, to sort of permeate the organization. We talked also about it being a team effort, right? There's going to be new and different people who have a seat at the table, particularly for clinical care, and as that gets woven into this overarching umbrella of compliance. And then again, we talked about this too, right? Compliance, the compliance function and the quality of care function, it's not static, right? It's not set it and forget it. It is, we are continuing, at least on an annual basis, to assess and evaluate or reevaluate what we're doing and whether it's working well, and whether there are changes that we need to make to continue to improve our compliance and quality of care.
Yeah. I don't know, Colleen, before I go, I don't know if you want to, there's nothing, no problem. I just don't want to step on anyone's toes. If you have any,
I mean, I think I would just say that the PDPM issue is something that we're watching very closely because it is being implemented for Medicaid in a lot of states. And so as things progress in that area, we will keep you updated. And obviously, because it is such a big part of compliance, as OIG highlighted, we're looking at it even more closely.
yeah. So we got a great question that says, I'm a compliance, or as a compliance officer, where do I draw the line on all of these risk areas relevant to compliance programs? And then the question goes on, can I get a report from staffing that they address this? Should I review staffing levels? Similar with care plans, what is sufficient on my end? This is where you get into the implementation. It's really easy for the OIG and the government agencies to publish guidance and tell you what they expect. It's another thing to take this and figure out what does it mean within the walls of your building and your program. So I am a firm believer that when the OIG speaks and when they've taken this long to speak, it's important. So I think the first thing you need to do as compliance officers, as administrators, as owners, is to spend time, print it, download it, whatever you need to do these days, and go through it. I would sit down and make sure if you don't have a compliance program, you really need to. And so if this is the inertia for that, fine. Okay, so you're gonna have to start it up. As a compliance officer, this answer depends a little bit on how you're structured. You should have a compliance committee that supports you. You should, if you didn't already, your compliance committee does need to be made up of folks who are handling and have oversight over some of these issues, whether it's a quality issue, it's care planning, somebody who has more of that clinical and condition of participation expertise, who will assist you, the compliance officer, as part of the compliance committee in developing the audit and report on the issue. Okay, so it's building out that work plan. You should have a work plan. If you don't know what it is, we can email me. We can tell you more about it, or any of us. And if you're the compliance officer and you don't have that support, I wouldn't be comfortable just getting a report saying they addressed it. That is not, to me, on just a black and white question, that doesn't sound like enough. I think you would need to add more to this for me to say, yeah, it's just not, did you speak to them? Did you go over it with them? Are they giving you a report on it? How are you comfortable? Maybe you already have systems in place that, doesn't, come into play here, like in writing a short question in a webinar. But I think you would want to be sure that you're comfortable that the person delivering you the report knows the issue, has done the review, and can present to you why you should be comfortable too. So you're allowed as the compliance officer to rely on the folks amongst your team or others in the organization and to speak with them on it. Care plans would be something similar. You're going to probably reach out to somebody with that better level of expertise on care planning, depending on, I don't know what your skill set is as the compliance officer. Are you already somebody from quality who's wearing another hat? I don't know. So it's a little bit hard to say, but the point is it needs to be coming from people with the competency to deliver it, to assist you. And I'd sit around a table and I would be talking about this report at my next compliance committee meeting. It would be on my agenda. It should be on your agenda. It should be circulated to your compliance committee members, and it should be discussed, and you should talk about, are you comfortable where you are? Do you have these items in your work plan? Have you done risk assessments to attest to see what your areas of risk are that need to be built into your work plan? So, like, we're talking about this big compliance umbrella, and we now have kind of the OIG coming up into what you're doing there. So I hope that that answers your question, but I think you have to get a little bit granular with this and work with your team on integrating it into your plan, because they might call it voluntary, and kind of David was getting at this before. They might call it guidance, but if you go and you look at different aspects of things, like when I'm handling, investigations with the government, they want to know about your compliance program as mitigating factors in kind of like culpability on issues. Do you have one? And the first question they're going to ask a nursing home is, what did you do with the OIG guidance? Did you look at it? Did you consider it? Did you implement it? Was it applicable? What'd you do with it? And you want to be in the position to say, of course we did. And we developed these things. Not everything was applicable, but they want to see that you're listening when they're speaking. And so I hope that helps you all today. I'm really grateful to my two colleagues here who are both, really, really good resources, really good experts in their area, and they're great speakers. And it was a pleasure delivering this. I hope everybody has a good day and happy holidays. And again, this recording will be sent out to everybody who registered. So thank you from everyone here at Garfunkel Wild. Have a good day.